Good evening, everybody. At the onset, I would like to thank Professor Jyotirmay Pal and Professor Aman Banerjee to ask me to speak on this topic. This is a topic which is quite common in our clinical practice, and it is always a challenge to correctly interpret thyroid function test. So, interpretation of thyroid function test is now generally straightforward. We have a lot of packages now coming up. You have all these ThyroCare packages. So each and every patient is getting all these tests done, and one of the integral tests which they are offering is a T3, T4, TSH. So most of the reports are quite straightforward and usually easy to diagnose. More than 90% of the patients investigated are diagnosed with a normal thyroid function test. However, sometimes all these reports which seem normal are actually misleading. An increased number of genetic defects are being identified in the HPA axis also. So what we'll be discussing today is why do we usually order thyroid function test. First and foremost, on suspicion of thyroid disease based on clinical signs and symptoms. Secondly, for screening of thyroid disease. And thirdly, and most commonly, for evaluation of patients who are already on thyroid medications. So these are the commonly tests which we do, a T4, TSH and T3, which has been routinely done. Nowadays, we have shifted more to free T4. Free T3 is an uncommon test to be done, and a different kind of thyroid antibodies which we have. Now, what is the reason behind TSH being the screening test? If you look at most of the screening guidelines, they only offer TSH as a guideline because it is central to the negative feedback mechanism, and tiny variations of thyroid function causes dramatic changes in TSH. So you'll find a T4 or a free T4 slightly going down will cause a TSH to rise manifold. So you'll get 100, 200 or a 0 TSH, which is quite dramatic and quite easy to explain to our patients also. Now we need to understand that TSH normally exhibits a diurnal variation with a peak shortly after midnight and another in the late afternoon. So it is important when your patient is getting tested. A patient getting tested at say 4 a.m. in the morning will have a TSH which is double to that of getting tested in 4 p.m. in the evening. So at its peak, the variation can be almost double. TSH values can be expected to vary as much as 20% between measurements without any changes occurring in thyroid function. So this is quite important because we get a lot of patients coming with reports from 5 different labs asking us the cause regarding the variation in their TSH reports. Now, the TSH can be decreased in the following conditions. If you have a TSH which is below normal, first and foremost is primary hyperthyroidism. You can also have a decreased TSH in patients recovering from primary hyperthyroidism. Many of the commonly used drugs like steroids, dopamine leads to a depressed TSH value. Non-thyroidal illness is quite important, especially for an internist. Many of the patients having even acute, say pneumonia, they'll be having a depressed TSH. A combination of pulsatile TSH secretion is also quite gaining importance nowadays. Now, if you look at the elevated TSH, commonly is the primary hypothyroidism, that is almost accounting for more than 95% of the patients. Rest is something which is more of an academic interest. You can have a pituitary adenoma, which is TSH producing. You can have cases of pituitary resistance to thyroid hormone, or a part of generalized thyroid hormone resistance, which is quite an uncommon entity. You can have it in old age also. We know that as the age increases, the normal TSH value increases. So that is also something which is quite important. If you are using drugs like amiodarone, we can have different changes in the TSH value. A significant patient have a high TSH. Recovery from any systemic illness. So if you have a patient recovering from acute sepsis, he'll definitely have a rise of TSH for a limited time period. We do not need to treat that. And if the patient is having any antibody in serum, which is again an assay-based thing. So usually in most of our conditions, TSH alone is helpful. There are some conditions in which we should go in for a T3, T4 assay also other than TSH. So if the patient is suffering from a central hyperthyroidism or a hypothyroidism, patients having non-thyroidal illness, patients undergoing treatment for thyroid illness, usually only TSH is usually not sufficient. Patients having TSH assay interference, patients having resistance to thyroid hormone, these are uncommon entities. Now, if you come to T4 or free T4 is the common thing which we do now. Free T4, the adult usually ranges from 1 to 3 nanomole per DL. Again, it depends on assay to assay, what method are we using. Now, this is a minute form of total T4 which circulates in the free form. It is not bound to plasma protein, so it is not affected by the plasma globulin or the albumin values. And a free T4 test should be performed to optimize thyroxine therapy in patients in newly diagnosed hypothyroidism. And in the initial part of hyperthyroidism, we usually treat by seeing the T4 or the free T4 value. Now, a free T4 or a T4 value is mandatory to diagnose secondary hypothyroidism and also in case of end organ thyroid hormone resistance. Now, these are the common conditions in which T4 may be elevated, the most common being hyperthyroidism or Graves' disease, in a toxic thyroid adenoma, in early phase of acute thyroiditis, or in hypermetabolic conditions. Now, T4 may also be decreased, especially in hypothyroidism, whether it be primary or secondary, or in tertiary also. So you have primary, which is a thyroid failure, secondary, which is a case of pituitary failure, and tertiary, which is a hypothalamic failure. Now, the different methods which we use, usually commonly what we use now is the CLIA. ELISA and RIA has been slowly outdated now, and FII is slowly being introduced, is still not commonly available. Now, two different antibodies which we use commonly in clinical practice are the anti-thyroid peroxidase antibodies or the anti-TPO antibodies. Usually it is more important in diagnosis suspecting Hashimoto's thyroiditis, and the anti-thyroid globulin antibodies, which is more important for the autoimmune thyroiditis or Graves' disease. We have anti-TSH receptor antibodies also, which is now available for clinical usage, which we commonly order for our Graves' patients. Now, TRH response test is something which is usually done by endocrinologists, not something which is very commonly done. Moving on to a test which is again a very commonly ordered is a radioactive iodine uptake test. So you have iodine 131 or 123 which is used to detect functional derangements of the thyroid gland. A small amount of iodine 131 is given intravenously, and after a few hours, usually 4 hours, 40 minutes and 4 hours the standard thing, the patient is monitored by a gamma camera. So normal response is usually 2 hours, 25% uptake occurs. And if we wait for 24 hours or delayed film, we can get as high as 50% uptake. The most important part of radioactive iodine uptake remains to diagnose thyroiditis. So if you are dealing with a patient of thyroiditis, usually this is the gold standard test which we order. So there is increased uptake in hyperthyroidism and decreased uptake in hypo or thyroiditis. So these are the common things which we get. These are the common pictures which is available. This is a crowded slide. So if you have, this is the most common thing which we get, which is a TSH is reduced and a free T4 or a free T3 is elevated, which is basically a condition of hyperthyroidism. So we have Graves' disease, toxic multinodular goiter, toxic adenoma, can happen in thyroiditis also. The other spectrum remains the TSH is going up and the free T4 and free T3 is going down. So this is hypothyroidism. Again, different combinations is possible. We'll be going into details in the next few slides. Again, a very important thing if you're facing a discordant TFT. So if you think that your picture is not fitting in any of the clinical conditions, first you need to reevaluate the clinical therapy. You need to understand the age of the patient. We need to understand that now we know that TSH is an age-dependent factor. So as the population is aging, the normal TSH goes up. So we need to inquire whether we are dealing with a neonatal period or the elderly period. A very important thing, whenever we are going in for any female, we need to ask whether the patient is pregnant. So in especially changes in pregnancy, we have a very low TSH in first trimester, secondary to increased HCG. We have increased total T4 and total T3 from second to third trimester, which is due to TBG. And there are changes in free T4 level also. Again, a very important factor, whether the patient is on levothyroxine. So this is a very confounding factor, and whether the patient is taking the medication regularly. If the patient is on any other medication, patient is taking amiodarone, simple drug like furosemide, sometimes can present a challenge picture. Heparin, steroid is notorious for causing depressions, so and dopamines. And if the patient is suffering from any concurrent illness, so if you have a patient of sepsis or maybe an acute illness, has been asked for a thyroid report, you will definitely get a challenging picture. So that is something which is quite important. The most common picture again is iodine deficiency disorder. We have increased TSH with a decreased T4. T3 will again depend on varying condition. Hashimoto thyroiditis, again, the same thing. We have increased TSH with decreased T4 and T3. Pituitary is again an interesting phenomena where all the three goes down. So usually if you have a T4 which is going down, it is associated with an increase in TSH. In secondary to pituitary abnormalities, all these three values will go down. And in non-thyroidal illness, you can have any of these combinations. Now, biological variations, as we have already discussed. During daytime, the serum TSH are low, whereas it rises by more than 10% just after midnight. So it is quite important when you are ordering the test. No increment of T3 or T4 seem to follow this nocturnal surge of TSH. So again, very important, this is a physiological thing and this is not something which is related to a functional status. Sleep decreases the TSH pulse amplitude but not the pulse frequency, as did fasting. Nocturnal physical activity may phase delay the rhythms. We have an important seasonal variation in T4 and TSH also. Serum T3 was higher during winter, while seasonal changes in T4 and TSH were less consistent. Seasonal variation has been suggested to be caused by ambient temperature and radiance, and an increase in T3 with cold has been demonstrated. So just to conclude, the results of thyroid function test must be interpreted in the light of clinical status of the patient, which is again necessitated. Whenever we are looking at the report, we need to look at the clinical picture of our patients also. Awareness of the associated conditions or disorders can guide for further investigations and management. Confounding factors should always be excluded before embarking on further biochemical, radiological or genetic testing. Very important factor is to look at whether the patient is on any other medications also. And referral to a specialist laboratory or an endocrine service is required when anomalous or discordant TFT cannot be readily explained by confiding the intercurrent illness, medication or assay interference. So three important factors which we always consider: whether the patient is having any intercurrent illness, whether the patient is on any other medications, and whether we need to change the assay method which is being followed. Thank you all for your patient hearing.
Thank you for good deliberation. Now the session is open for question answer session.
Yes, sir.
With reference to thyroid function test, particularly the elderly population, geriatrics,
Yes, sir.
the cutoff values of TSH, etc., would there be some difference? Because of clinical hypothyroidism in elderly might have a lot of problems, sometimes not diagnosed, might cognitive dysfunction or coronary artery disease, etc., dyslipidemia. And to treat them or not to treat them with L-toxin, etc., sometimes becomes a problem. So what is your suggestion in that situation?
Sir, now we know that TSH follows an equal distribution with age. So as the age goes on increasing, the normal TSH values also goes on increasing. So according to the recent, we had a paper in JCM also which went on to show that possibly now we should have an age-dependent TSH values. So possibly for a patient of say 40-50 years, a TSH of 4.5 is normal. If you look at an elderly of say 70 years, a TSH of 6.5 is also normal. So again, this is not something which has come in the standard guideline, but there are a lot of papers which are coming up, which is showing that possibly the concept of subclinical hypothyroidism also needs to be changed. For an elderly of say 80 years, a TSH of 7 to 8 is perfectly fine. We do not need to treat that patient. We need to understand that their metabolism is slowing down, and TSH is very much related to the metabolism of the patient. So as the age increases, the metabolism is slowing down, the TSH will definitely rise. That's a sign of possibly the metabolism which is slowing down in the body. We do not need to treat that.
Thank you.
Thank you.